Hey everyone, and welcome to this explainer. Today, we're diving into a piece of human machinery that we literally use all the time, but probably completely take for granted. I'm talking about the deltoid. You know, that rounded muscular contour right at the very top of your arm? Well, it turns out it's way more than just a single muscle doing one simple job. It's actually this fascinating multifunctional powerhouse that essentially drives all the major movements of our shoulder. So, let's just jump right in. But first, picture this. Think about the last time you went to the doctor for a vaccination. Where did they put the needle? Right in the shoulder? In the deltoid, right? But have you ever actually stopped to wonder why? Out of all the places on the human body, why is this specific muscle the ultimate go-to spot for an intramuscular injection? Well, the answer lies in a really beautiful, complex web of anatomy that's hidden just beneath our skin. And by the end of this explainer, you're going to understand exactly how this space is engineered. To reverse engineer this little anatomical mystery, here is our roadmap for today. We'll start with 1, the protective hood, then 2, anatomy, origins and insertion, 3, 3 muscles in 1, 4, axillary nerve connection, and finally, 5, clinical risks and injections. All right, let's kick things off with section 1, the protective hood. And really quickly, just so you know, everything we are breaking down today comes directly from a highly trusted medical source. We're using Vishram Singh's textbook of anatomy, specifically the volume covering the upper limb and thorax. This text gives us the real, grounded mechanics of how our bodies actually operate. And the text uses this brilliant visual metaphor right off the bat. It explicitly describes the deltoid as a muscle that literally covers the shoulder like a hood. It's not just sitting flat on your arm. It drapes entirely over the shoulder joint. And underneath this muscular hood, it's a crowded, busy intersection. It hides the upper end of the humerus bone, the coracoid process, the glenohumeral joint, a bunch of ligaments, and several lubricating sacs called bursa. It even covers the attachments of a whole host of other muscles. The deltoid is basically the grand protector of this incredibly complex and honestly somewhat fragile joint. Moving right along to section 2, anatomy, origins and insertion. When you think about the sheer width of the deltoid's origin, it's pretty wild. It doesn't just attach to one bone. It anchors across this massive continuous arch right at the top of your shoulder. At the front, it grips the outer third of your collarbone or clavicle. Then it sweeps around the side, attaching to the lateral border of the acromion, which is basically the bony roof of your shoulder. And finally, it reaches all the way around to your back, anchoring onto the lower lip of the spine of the scapula, your shoulder blade. This wide, sweeping U-shape is exactly what gives the human shoulder its smooth, rounded contour. So you've got this massive, wide sheet of muscle starting from the front, side, and back. But where does all that tissue actually go? Well, it all converges downwards into one single, highly focused insertion point on your arm bone, the humerus. This spot is a characteristic V-shaped bump on the outside of the bone, perfectly named the deltoid tuberosity. Just imagine a wide protective cape gathering together to tie at a single, precise point halfway down your outer arm. This brings us to section 3, 3 muscles in 1. I absolutely love this quote straight from the textbook. It says, the deltoid muscle is like 3 muscles in 1. Because it wraps around the front, side, and back, your brain can fire different sections of this single muscle completely independently. It pulls that V-shaped insertion point we just talked about in entirely different directions. Let's break down exactly how this works. The anterior part, at the front of your collarbone, handles flexion and medial rotation. Basically, think of reaching forward to grab something. The posterior part, on your back, handles extension and lateral rotation, so pulling your arm backward. Both of these are unipennate muscles, which just means their fibers run parallel in one direction. But the middle part, the acromial part, is structurally different. It has a multipennate architecture. This weaves the muscle fibers into multiple tendons, kind of like a really complex feather. This specific structural upgrade makes that middle part the absolute strongest section of the deltoid. It gives it the massive power needed for abduction, which is lifting your arms straight out to the side against gravity. Just to emphasize how crazy this is, you literally have anterior flexors and medial rotators directly opposing your posterior extensors and lateral rotators. These are completely antagonistic movements, pulling frontward and inward versus backward and outward. Yet they live within the exact same continuous sheet of the deltoid hood. It is a masterpiece of biological engineering. It allows for this incredible range of motion just depending on which specific fibers your brain decides to activate. But here's where we find a really fascinating mechanical quirk. That super strong, multi-pennant middle part of the deltoid, it actually cannot start lifting your arm from a resting position at your side. No way. From 0 to 15 degrees, the deltoid's vertical pull just jams the arm bone straight up into the shoulder socket. It doesn't pull it outward. It has to rely on a smaller muscle underneath called the supraspinatus to initiate the lift for those first 15 degrees. Only once the arm is slightly angled can the mighty middle deltoid take over, carrying the weight powerfully from 15 degrees up to 90 degrees horizontal. So what happens when you want to reach higher than horizontal? Well, above 90 and especially above 120 degrees, the deltoid and the arm bones simply run out of joint space. The bone literally hits the roof of the shoulder. To go higher, your body relies on something called the scapulohumeral rhythm. Basically, for every 2 degrees your arm joint moves, your entire shoulder blade, the scapula, has to rotate outward by 1 degree on your chest wall. It is this beautiful, synchronized dance between the arm and the shoulder blade that gives us humans our incredible overhead reach. If the muscles controlling this rhythm get paralyzed, your shoulder movement is severely crippled.
Let's move on to Section 4, the axillary nerve connection.
The deltoid muscle gets all of its operating instructions from the axillary nerve, which stems from the C5 and C6 spinal segments up in your neck. This nerve has a very specific and, quite frankly, highly vulnerable pathway. It comes from the armpit area and winds tightly around the back of the surgical neck of the humerus. That's the slightly narrower part of the arm bone just below the shoulder joint. It sits right there, totally exposed, directly under the protective hood of the deltoid. Which perfectly sets up our final section, 5 clinical risks and injections. See, if you suffer a severe shoulder injury like a downward dislocation of the joint or a fracture to that surgical neck of the humerus, that axillary nerve is right in the crash zone. If it gets damaged, the clinical signs are pretty immediate. First, impaired shoulder abduction. You literally just lose the power to lift your arm out to the side because that middle deltoid is paralyzed. Second, loss of shoulder contour. Over time, the muscle wastes away, and the bone underneath becomes this sharp, prominent point. And third, sensory loss. A branch of this nerve supplies the skin on the lower half of the deltoid. Doctors actually call this the regimental badge area. If you lose feeling there, you know for sure the axillary nerve is compromised. Now, there are other clinical risks under this hood, too. Remember we discussed the subacromial bursa, that little fluid sac meant to reduce friction? Well, in many people, especially males over 50 or athletes doing a ton of repetitive overhead motions, calcium can deposit on the tendons, and that irritates the bursa. When you try to abduct your arm, this inflamed, swollen bursa gets pinched tightly between the moving tendon and the bony roof of the shoulder. This creates a really specific window of severe pain, precisely between 60 and 120 degrees of lifting your arm. Clinicians call this the painful arc syndrome, and it's a classic sign of rotator cuff disease occurring right underneath our deltoid. Which finally brings us full circle back to our opening question. Why use the deltoid muscle for injections, and specifically where do we aim? Well, the deltoid is thick, it has great blood supply, and it's super easy to access. But, as we now know, there is a major hazard hidden inside, the axillary nerve wrapping around the upper dome. So to safely deposit medicine into the muscle without hitting that electrical wiring, medical professionals are trained to target the lower half of the deltoid, or, more practically, the upper and outer quadrant of the region. This perfectly utilizes that thick, multi-pennant muscle belly while keeping the needle far, far away from the delicate nerve hiding deeper up in the hood. So the next time you effortlessly reach forward, swing your arm back, or lift something straight out to the side, I want you to just take a second to think about what's actually happening. Think about that wide protective hood. Think about the anterior flexors, those powerful multi-pennant middle abductors, and the posterior extensors all seamlessly coordinating together. Will you appreciate the complex 3-in-1 machinery firing perfectly right beneath your skin? I certainly hope so. Thanks so much for joining me for this explainer. Keep feeding that focused curiosity, and I will see you next time.